So it's timed through like everything else, and you understand we have to time things. But what you'll first do is there will be 4 of us in there, and there's usually 2 at the med station, and then we usually have 1 at reconstitution, and then we have 1 over at the site spot. So when you first sit down, when you first come in, you're going to have a box like this. You need to bring your med books. You guys all have drug books? Yes? Bring your drug book. You will need it. Okay? And the reason is you're going to have this little box, and we're going to hand you a packet of papers like so. Okay? This paper on the front is going to give you a scenario. It's going to tell you your patient and her age and what's going on with your patient. It's going to give you vital signs. It's going to go over the entire thing with you. Okay? Make sure you zone in on what we're telling you about your patient, whether it's pediatric or adult patient. The next thing you're going to get is a physician's order sheet. So it is going to give you a list of orders. Everybody knows how to read orders. There's examples in your skills book of physician's orders, yes? So make sure that you look over those and you understand physician's orders. You know that a complete physician's orders has to have a date and has to have a time, and it has to be signed by the physician, yes? Mm-hmm. And for any administrations of meds or anything, it has to have the name of the med, it has to have the route, it has to have the time, it has to have the frequency, okay? So if you don't see that on your orders, then you would need, when you're ready and you're all set to pass your meds, you're going to call the instructor over and you're going to say, I noticed on this there wasn't a frequency or there wasn't this. I would call a physician. So you guys will have to pick that stuff out if it's missing on your order forms. Bring your med book, because I may tell you to give medication, and I'll give you an example, digoxin, okay? If I tell you to give digoxin, there's parameters with digoxin. If their heart rate's below 60, would we give it? No, because it does what? Decreases the heart rate, so we don't want to kill our patients. So if I give you on this page vital signs that say heart rate of 44, and I give you an order here that says digoxin 0.025 micrograms, are you going to give it? Probably not, and you're going to notify the physician. Anytime you hold, you have to notify the physician. Okay. I may tell you on here there's allergies listed, so to tell you if the patient has allergies or the patient doesn't have allergies or whatever. If your patient has allergies to penicillins, but on here you have amoxicillin ordered, are you going to administer that amoxicillin? So these are things you need to be looking at on here, because that's what's going to get you through it. Okay. Attention to detail. And you'll need your med books, because when you're looking at these meds, you're going to want to look each one of them up and see the classification of drug, parameters for the drug, and contraindications for that drug, so you can safely administer it to your patient. And I would look up each drug unless you feel very confident that you understand and you know that drug. You have a patient that comes with a GI bleed. Do you want to give them NSAIDs? Do you want to give them ibuprofen? Probably not. Or aspirin? Maybe not. If they're on blood thinners like Coumadin or heparin, we probably don't want to do that either, right? So be careful if you have bleeders coming in. Make sure you look at the times. So if it says HS, you guys know, and really they're not supposed to use HS, they need to put at bedtime. But most of these are written correctly, where they'll tell you every 8 hours or they'll tell you bedtime. You know PRN is as needed, so you're familiar with all your terms. On all these sheets you will also have, so once you check off on your meds and you decide you want to give them, you're going to look in your little box here and you're going to pull out everything you want to give. So some of them say like Practa this and Practa that, because obviously these aren't real pills, but you still should be able to match them up. Okay? If you get stumped, then you call one of the instructors and we'll assist you. So you'll pull your pills out, you'll call the instructor over and you'll say, I'm ready to pass my pills, and that's when we'll go over everything, and you're going to tell us if there's anything missing, anything that's contraindicated for your patient or unsafe for your patient, and what you're going to do and what you're not. Okay? Once you've passed that portion, at the bottom of all these it says FSBS. Does everybody know what that is? Finger stick blood sugar. Sometimes it's FBS, fasting blood sugar, finger stick blood sugar. That's your blood sugar. Okay? So on your checkoffs here, or on your order forms, it's also going to give you directions to give insulin. There's going to be sliding scales on here, and there's going to be NPH. So everybody know what sliding scale is? All right. So let's talk about sliding scale. And doctors, you have the doctors, they write different ones. I had a doctor before that would write his sliding scale like this, and he would say minus 50 took whatever your blood sugar is minus that, divided by 10, and that's what you gave. They all have different types of sliding scales. You do what's ordered on your paper. You guys will not have that one because that's an endocrinologist and his special thing. What you guys will have on here is, like this one says, if it's less than 150, equals no units. 151 to 200 equals 2 units. 201 to 250 equals 4, and so forth. You guys get the gist of it?
Yes.
So you're going to have to take your blood sugar and identify what you give or what you want. So if you have a patient that has a blood sugar of 204 and you tell me you're going to give 2 units, is that correct?
No.
Or if you have a patient that has a blood sugar of 130 and you tell me you're going to give them 2 units, is that correct? No. So that's what the sliding scale is going to be about, okay? Just to get you familiar. Then you might have an order, some of you will and some of you won't, on your order form to administer NPH, okay? You need to be familiar with regular insulin and NPH insulins. Those are the two that will test you on. And that means onset peak durations, okay? So be familiar with those. You'll have your drug book, so you'll be able to use your drug book. Those are in your drug book. If you have NPH, so for example, this patient has NPH, you have to administer both. So everybody knows what an insulin syringe looks like this, correct?
Yeah.
Okay. You have insulin syringes in your kit, and you have 1 milliliter syringes in your kit. Make sure you bring the insulin, and on the back, it will say right here, insulin syringe. You cannot draw insulin in a 1 ml syringe. Not safely. Okay, so make sure you bring your insulin syringe. So you're going to draw your insulins. So we've determined, we'll say my patient has a blood sugar of like 204, and I'm going to go ahead and give him some insulin. Now, if you have a patient who has not eaten their breakfast, and they're vomiting, and they're having issues, do you want to give them insulin? Probably not. We can go ahead and check their blood sugar to see where it's at, because that's standard of care. We need to assess the patient. And then we can notify the charge nurse and the physician and let them know we're going to hold because the patient's actively vomiting. Okay. Now, obviously, if I took his blood sugar and it's 600 and he's vomiting, I have to cover the patient. Okay. But I probably wouldn't give him NPH. You might just get some regular sliding scale for right now. So that's one exception. If your patient's NPO to go for a surgical procedure, and you check their blood sugar and it's like say it's 151, I call the doctor and say, hey, he's 151, he's NPO, he's not scheduled to go till 11 o'clock. Do you want me to go ahead and give the sliding scale or hold it? Because I would hold it and call the physician, because if I give that to him, I might bottom him out and I can't give him any food because he's NPO. Make sense? Okay. So this patient's eating whatever, 204 is the blood sugar. So I'm going to go ahead and give the patient, 4 units of regular, and they've got 10 units of NPH ordered. Okay. So you guys have NPH, and I'm sure you guys have looked at it, and it's got that powdery stuff at the bottom. We don't do insulin like this. We don't get to shake it. You just agitate it like this until you can get it, where it looks cloudy like that. Okay, so there's no sediment on the bottom. That shows that the medication's mixed in there appropriately. These are multi-dose vials, so they're used more than once. This is a brand new vial of regular insulin, and this is a used vial of NPH insulin. And when I tell you that, it's because when I pop this off, do I have to clean the top of this? No, because it's sterile. When I come back at lunchtime to recheck it, am I going to clean it? Yes, because the cap's been removed. You guys picking up what I'm putting down? Okay. This one was not capped, so I would take my alcohol, and I would go ahead and clean the top of this one and let it start drying. Okay? Do you guys know how to draw insulin clear cloudy? Yes? Haven't done it? Okay. So insulin goes clear cloudy, all right? And how we want you guys to do that is, and I want you guys to get your syringes out at some point. If you don't want to do it now, it's fine. Get familiar with your syringe and make sure the one you check off with is the one that you're familiar with. And the reason I tell you that is because I failed students on insulin several times. Because if you look on my syringe here, I have a toggled number. And what I mean by toggled is this. 25 sticks out big like that. And over here it says 26, but over here is 27 with a little one, and over here is 28. You guys see what I'm saying? Some of them will go like this. 5, 10, and then they'll have little ones in between saying 6, 7, and 8, but you just go 1, 1, 1 like that. Most of these are toggled. So you would go 5, 6, 7, 8 to count them out. Do you guys see what I'm saying? Be familiar with your syringes because I've had people not give enough or too much by not looking at the type of syringe they have. This is a toggled syringe with toggled numbers. Okay. All right, so I've cleaned all these. Clear to cloudy. Clear to cloudy. Okay. You wake up, it's clear. After you get done at school, it's cloudy. Just remember it like that. Wake up, go to class, it's clear. You get done listening to me, it's a cloudy day. So I'm going to go over here. I need 4 units of regular, yes, and I need 10 of MPH is what my order says. So I've already agitated this and cleaned it. This was freshly opened, so I didn't have to clean it. Okay. So total units are going to be how many? 14. These have safety locks on them. These little things are safety, and sometimes they're hard to read through. You can lift them up a little bit, just don't lock them. So see how mine's lifted, but it'll go back down. Just don't lock them. You can lift them all the way up so you can read because they kind of lock. Y'all come stand, get around however you need to do to get to see. I promise you I won't bite. Yes, my breath stinks, but it'll benefit you in the long run. So if you guys look at this, you can actually pull this up. Okay, you see the toggle numbers, how they're kind of toggled. Just get familiar. So I go ahead and do this. So now what I'm going to do is I'm going to go ahead and draw back air, and I'm going to draw back 14 units of air. Okay. So I notice here that that's 11, and these are some kind of sticky. 11, 12 is on the other side, 13, and 14. And if you need a magnifying glass, feel free to bring one to class. Some people have to have them. These are really little, and some of us are getting older. So, all right, so what I want to show you is, let's see, 15 is way down here, and I'm going to go right there. Okay, so I've got mine marked. Sorry, let me show you how to cap the needles appropriately, not the, so we don't want to stick ourselves, so that's how we cap our needles back. We don't, because that's a stick. So you lay them down. Don't touch the needle to anything except in there because your needle's sterile, and then it goes straight into there, okay? These are super deluxe ultra fine needles, so you can't stick them in here and let them sway around and not hold this and support it because it'll bend your needle and break it off. Super ultra fine. So I've got 14 units of air in here, and if you guys look at the top, you have a plunger. Do you guys see the little black plunger here? So you see kind of like a top and a bottom right there. It should line up with the very top right there. It should line up with the bottom level portion with that line. Do you guys see what I'm saying? Do you want to pass that around and look where I've got it? Just try not to hit the plunger. So it needs to line up perfect. So you want to line it straight up with the top, because if you do it at the bottom, that's going to be less. Do you see what I'm saying? So it lines up with the very top curvature. So like, so what I'm saying is the little stopper thing's kind of like this. You know, it kind of goes like this. You want to line it up with the top part up here, not down here. Because if you do it down here, it's going to push it up farther and you won't have the right amount. Does that make sense? So the top portion of it, so you'll have your exact amount. Okay. When y'all get done, I'll draw for you.
You want to use mine to draw?
Sure. Okay. So she's got hers set. And what I do, it can make it easy for you, is if it's 14, I go to 15, and then I go straight across because I know that's 14. And then I'll count mine out. So I have 14 now. So what do I draw first? Clear. Okay. So I'm going to draw this last, right? And it's already settling on the bottom. So the first thing I'm going to go ahead and do, how many units of this am I drawing?
You're going to inject 10 units of air.
I'm going to put 10 units of air in here. So I'm going to put this all the way up until I get to 4. Okay? And then I'm going to come over here and I'm going to inject the rest because I've already cleaned these. And there's my 4. So now I'm already in here, and this is the first one I draw. So I'm going to go ahead and draw my 4 now, correct? So I'm going to draw my 4. And if you go past, you can kind of go back until we get to 4. So I'm at 4 units. You have to support these. Don't let go of them. I've seen students turn around at things hanging in the needle bust off. So you have to support your vials. So I've got 4 regular, and now I'm going to go in here. Now here's the tricky part. This is a fast-acting insulin. This is a long-lasting insulin. I don't want any of this in here, okay? So you have to be right on point, exact what you draw at this point on, because I can't push back in like I did with this one because I can't put any regular insulin in this. So get prepared. So I'm gonna go in here. Be careful with my plunger that I don't push it in, and I'm gonna go ahead and draw back. 11, 12. There's 13, and there's 14. So I drew my 14. Oh, she doesn't have a cap. I would put my cap on right now. And then what you'll have to do is when you draw your air up, I don't check your air. You inject your air. You'll inject your air, but each time you draw an insulin, you have to have it checked by the instructor. So I'll be standing there, or Miss Rutherford or Mr. Hughes. And so when you draw up your regular, you'll take that out and you'll hand that there and let them check and say 6 units. And we'll check it. And then you'll proceed to the next. And then when you're done drawing that, you'll hand it back and say a total of 12 units or whatever you have. We have to check each one of those. So don't draw everything up and say, there you go. I have to check this one and I have to check that one separately. And then after you're done, I'll check. Do you guys see what I'm saying? Mm-hmm. So I have my insulin in here. It's been checked. And most facility policy is it's a 2-nurse check anyway because this is a big deal. Anytime you draw insulin, I check it, and then I would go over here to Deanna and say, hey, I just drew up 12 units of regular, and have them check, and then both of you actually sign the MAR, ensuring that 2 nurses have checked this, okay? And that's CYA, and that's policy in several facilities, almost all facilities.
I would say most, yeah.
So make sure you always get your insulin double checked. Don't draw it up and just run in there and give it because that could be a big deal. So double nurse check. So we're done with that, okay? So my next check off part is I'm going to go to the Reconstitution Center. And you guys should have these in your kits. Yes? Do those look familiar?
Yeah. I have one question before you move on.
Okay, go ahead.
When you inject the air,
Mm-hmm.
do you have to turn it back upside down? Because I'm thinking if you're going clear to cloudy, then if you turn it upside down, the needle is touching the cloudy. So if you put it in the air, could you possibly just go like that and just push down the air?
Yeah, you can. You
Okay,
can.
I was just wondering.
I mean, it doesn't matter where you
Okay.
inject the
I
air
just didn't
into.
know if,
The
okay.
thing is, you just want to inject the air in here first, and then in here
Yeah,
second,
yeah.
because you put it in there, and then you can just inject and draw, and then go
Yeah,
back.
for sure.
And then you guys need to know, where would I give this insulin injection? Is this a sub-Q injection, an IM injection?
Sub-Q.
Sub-Q. So keep that in mind, okay? So we're going to do that. I'll come back there in a minute. So now we're going to reconstitutions, and you'll be given a little card there that's going to say you have a patient that they've ordered Brocefin, let's say, we'll say 500 milligrams IM times 1. So how you do reconstitution is this is your medication, and this is your diluent, okay? So if you look on the back of these, it's going to tell you, it gives you a choice. You get to pick. It has 300 milligrams per ml, it has 400 per ml, and 500 per ml. So if I'm going to give 500, it makes sense for me to do 500, right? That's easy to figure. The big thing is, when you draw these up, is you have to make sure that you understand you can't inject somebody with like 5 mils of fluid. Okay, that's a lot. That's a lot to put into somebody's arm or into the gluteal areas, dorso or ventral gluteal. So the key to this is being able to figure it and administer the lowest amount of fluid. So I would like optimally to have no more than 1 ml that I'm going to have to inject. Okay. So I'm going to pick the 500, and right next to that, and just read the back. This is like dummy proof. This is Reconstitutions for Dummies, and it's on all of them when you go out in the real world. It tells you here the strength of your powder. It tells you here the amount of diluent that you're going to add, and it tells you the type of diluent. It tells you right here at the bottom what you're supposed to use. So I'm going to use sterile saline. Okay? Do I have to clean that?
No.
Do I have to clean that?
No.
Not unless I do this after I take it off, but I don't usually do that.
Or lick it.
Okay, so next thing I'm going to do is 500 mLs. For me to yield a medication in here that is 500 milligrams in an ml, I have to dilute it with 5 ml. Hang on, my eyes are not. 5.6. You guys have bigger syringes in yours. I do not. This is what I have in the lab. You guys probably want to bring your 5 and 10 ml syringes. So what I'm going to do now is I'm going to draw up, and you can put inject air there if you want. I don't care what you do. Okay, I'm going to draw up my 5.6 mLs, okay? And we're going to pretend that I get 5.6 out of this one time. You might have to go back and forth a couple times, but. So I have 5.6 mLs in here. I'm going to inject it. Oh, that's probably one of my kids. Yep. And I'm going to put it in here, okay? I'm going to take this out. And we'll have the sharps containers in there so you guys will be able to dispose of your sharps. And then we don't do those with them either. We just kind of agitate it to mix them. Everything you want to agitate. So that's mixed. So now I go to the next thing here that says volume of reconstituted solution. So that means I've put in my diluent and I've mixed it. So this says I should have 6 mLs in here, okay, which I don't. I only have probably 3 and some change, but we'll pretend. So I should have a total of 6 in here if I need it, but I know that I only need 500 milligrams, right? And this tells me right here, once I dilute it, for every mil, there's 500 milligrams. So how much am I going to draw up to give my patient? 1 ml. So I'm going to draw up my 1 ml, and you can go ahead and you can draw it up with this syringe. Just my biggest thing is these needles are sterile, so don't touch them on anything on the tables or anything like that. You need to just appropriately get them in and cap them, and they'll be fine, okay? So I can use this to draw. So now I need to clean this because it's already been used, so I would clean it with my alcohol, let it dry off, and then I'm going to go back in here. Now, you see my needle tip is in the air?
Yeah.
It's going to draw air. So sometimes you have to pull down a little bit to get the needle in the fluid. If you're drawing in fluid, you get fluid. If you're drawing air, you get air. I don't care if you put stuff back in here, pull stuff out, trial and error and get it, but your top line should be your 1 ml. Oh wait, that's half, sorry. There we go. So your top line should be even with your 1 ml. And then I'm just going to be carefully capping my needle here. But there's one more step to this. I have poked this stopper twice, or maybe more times actually, 1, 2, and 3, right? Did I poke it 3 times? I drew it out of here, put it into there, and then put it back in there, so 3 times. So do I want to use this needle on my patient? No. Probably not. So you need to bring an extra needle. So what you need to do before you change it, do I want to just take this off right now and change it?
No, you want to pull back.
You need to pull back because you have a lot of medication in that lumen on the needle already. So we're going to pull that back like this, get all the medicine out, make sure we have it down. I'm going to twist this needle off, put it in the sharps, and grab my new needle over here and put a new needle on. And then I'm going to put my medicine back in here. Just be careful that you don't get rid of a lot of medicine because you still need to have your 1 ml. If there's any air bubbles, get those out, and y'all can pass that around. That's what it should look like. 1 ml, the top stopper line, okay? If I'm wrong, please feel free to tell me, because sometimes, I'm human too. Did it look okay to you?
And you often want to change your needle because you may want to draw it up with a much larger bore needle than what you want to give it with.
If you ever have to give testosterone,
Oh, God.
I usually use like a 20 or 21 to draw,
it up?
and to inject, because that's just like syrup. You'd be in there for like 2 hours with a needle and somebody's behind trying to put the testosterone. It's like, it's thick. So you want to know the viscosity of what you're actually injecting to.
For the insulin, because you drew 4 of one, 2 of the other,
Uh-huh.
is there like a ratio, or does it say this and this? And
No,
this and
it
that?
tells you order.
It's
It
gonna
tells you
tell
the
you.
order
It's
on
the
here.
order.
Like this one tells me 10 units of MPH, and this tells me my sliding scale, and that's what I'm basing that on. You just always have to know clear to cloudy. And when you're drawing your clear, you have a little bit of play. If you go over, you can put it back. But
Right.
once you've drawn that and you go into the cloudy, you got to be going really slow and making sure you're right on, because you can't go back. And if you mess it up, you have to start over because you can't tell what they're getting. So it's real critical in that part.
So you have to put air in the first one?
Insulin, they want you to put air in here.
Okay.
Okay, and that's insulin. And I'm going to be honest with you guys, I don't do that when I practice. I care less if there's air in there or not. It's a nurse thing that Florence Nightingale did, I guess, and everybody else feels that we got to carry on the tradition. I draw insulin. I don't shoot air into it because to me it doesn't make a difference if there's air or not. But for testing purposes, you need to put the air in.
Air in that one. then
Now,
come in
if you come over here and you're nervous and shaking like this, like all you guys do when you come to check off, and you accidentally come over here and you put your air in there first and you're like, then just go put it in here and then just go back over. You'll just have to clean. I mean, it's okay to do that. I just tell you to put it in here first and there, so once you're in here, you can just, cutting out the steps. Okay? And make sure if you get, if you're reusing these or whatever, that you clean them, because we'll fail you for that, because that is a big patient safety thing. If they're not clean, you can't give that to the patient.
And the amount of air we put in is the amount we're going to be pulling out.
Yes, that's exactly
That's
right.
kind of like a double check for you to
Yeah.
Cassie.
We don't check the air. I won't check the air. You'll draw up the air and blah, 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 and you'll inject it. The only thing I'm going to check is what you're putting into the patient. So when you draw the regular out, I'm gonna say, let me check that, and I'm gonna look at the regular, and I'm gonna say, okay, and I'm gonna hand it back to you, and then you're gonna draw your NPH, and when you get done, you're gonna hand it to me, and I'm gonna say, how much of NPH did you draw, and that, and I'm gonna look at the total number, and I'm gonna say, okay, you pass. That's how we're gonna do it.
So we're not actually administering anything.
No, you guys have injector pads in there.
Yeah.
I wouldn't recommend, I mean, you can use them if you want, but the thing is what goes in has to come out. So if you're gonna inject some in, you gotta draw some out and then blast it away and get rid of it. Because if you keep putting it in, it's gotta go somewhere, right? So what you put in, you kinda gotta take out. So if you wanna put it in your, they leak and they're kind of yucky. If you wanna use them, you can. Please do not inject anything into anybody else or whatever, you don't just,
And then do you give us a blood sugar, or are we actually gonna take like?
we'll give you a blood sugar.
Okay.
And we'll talk about getting blood sugars here in a little bit. So, that IM injection I just drew, I just told you. Is it IM injection or something? Okay, so IM injection is what the reconstitution is going to be. So, you'll need to know your next checkoff station is you're going to take your little IM injection you drew up, and you're going to go over there and you're going to show the next person all your possibilities of IM injections. So, we're talking about deltoid, dorsogluteal, ventral gluteal, vastus lateralis. And you're going to have to tell me your landmarks and how you're identifying those. So you're going to tell me that you would place, your hand right, the palm of your finger right here on the acromion process, and you'd go 2 to 3 fingers down before you inject in there. And do we aspirate on IM injections?
Yes.
Always. Why?
You don't want to be in a vein.
Because we don't want to mainline them. So you aspirate your IM injections. So you'd say I'd inject, aspirate. If no blood seen, inject the medication. If blood is seen, you withdraw and you do not insert the medication, and you would go back and redraw your medication and come back and redo the injection, not in the same spot. Okay?
Okay, so you put an IM needle on there, or is that what you said?
Yeah,
this
that's
is
what's wherever it's passed around.
Okay,
somewhere.
all right, okay,
Yeah,
gotcha. All right.
that's
I
that's
was still
a-
looking at that one, I
That's a
was
20,
like,
isn't it?
This is a 20 gauge, and it's got a 1-inch needle on there.
Okay.
It's a 20. Yeah, it's little though. I wouldn't use that for an IM injection, but this is all I have.
Okay.
I'd use probably. I mean, you can use a 1-inch if you have a smaller person. If you have a bigger person, you need to use a 1.5 or a 2. And sometimes, when we do ventral gluteal, I've used spinal needles on some morbidly obese patients to
I
do a
have
ventral
too.
gluteal, and they're pretty good size.
More than once.
You have to keep in mind, a IM injection means exactly what it tells you, intramuscular. So you have to get to the muscle. And if there's 8 inches of adipose tissue you have to go through, you have to use the appropriate, you know what I'm saying? So that's why sometimes we've used spinal needles. So you'll have to go over and you'll have to show me. The sites that you're going to have to be familiar with is going to be the deltoid, the vastus lateralis, and so you're going to have to show me how you place your hand on the kneecap and split it into 3s. Dorsal gluteal, you're going to have to show me how you cut the butt cheek into 4 quads and you go the upper outer quadrant. And ventral gluteal, which is on the front right here, that you put the palm of your hand on the superior anterior iliac crest, and how you adjust your hands to know where you're going to go right in there to inject. So look over all those injection sites, know your landmarks, because you will have to show me. You can't just tell me I would do this. You're going to show me those sites and how you move things to pick those sites, because you have to know that. You can't give an injection if you don't know how to find the site or how to give it correctly. Okay?
And that's only for IM injections?
That's going to be for IMs, but you need to know where all your sub-Q spots are. And your book tells you how many you have on the fronts of the thighs. It tells you how many you have on the backs of the arms, on the abdomens, and actually on the back. So know all your spots. It'll tell you 18 here, 20 here. We'll ask you how many sub-Q injection sites do you have, and you'll have to tell us how many here, how many here, how many here, how many here, and how many there. And know how to find a sub-Q site. Do we aspirate on sub-Q injections? No, we don't. You do not aspirate sub-Q. Only IM. We don't aspirate intradermal injections. If we give a TB test or a Mantow test, we don't aspirate. That's going into the dermis. Are we worried about hitting a vein there?
No.
Hopefully not. Okay? So, yes, you need to know angles. I'm getting there. You'll need to know angles. So, sub-Q angle, you need to know what your book tells you. An intradermal, I will ask you, what about the intradermal? Be familiar with the size of the needles. Would I use a 20 gauge 1-inch needle on an intradermal?
No.
Probably not. So know your needle sizes, know your angles. IM injection, 90 degree angle, we go straight in. Okay, sub-Q, I think your book tells you 15 to 30. Is it 15 to 30 maybe on that? Or they tell us 45? Or they tell them 45? Oh, intradermal. Intradermal is 15 to, that's something. Intradermal is 15, 30, and I think the sub-Q tells you up to 45. Now, you will see in practice that you will have somebody with insulin like this, and they will go into a patient's room, and they're going to do a straight 90 degree. That is okay as long as the patient is obese, because that's why they're doing it. There's no way that this little needle is going to pass that adipose tissue. That's acceptable. Those are the only patients it would be acceptable on, okay? So, any questions about injections? Know your landmarks, know your sites, okay? You're not going to have to do an intradermal, and the only thing intradermal we really give, unless you work in an allergist office, is going to be the Mantel test for the TB. And if you go to jail, you'll be an expert on those by the time you're gone, because we do probably 100 of those in a day. So that's the big thing about that. So after you check off there and you've shown them all your sites where you would give that, you finally get to go to the easy part of the check off. And that's where they have this little cup. So you should be familiar with the little cups. You guys have one of these in your kits, don't you?
She gave us.
So it tells you like the mLs and the cc's and blah, blah, blah. And we're going to tell you, your patient has a cough. They want 1 teaspoon of Delsum. Pour it. And we're just going to have you pour it. You know you always place these on a flat surface. We don't get to do this. I say, you have a magical eye if you can do that without moving, you know. So the thing is to put it on a flat surface and to make sure that the bottle or whatever the thing is you're using to administer the drugs, if it's a bottle or a vial or whatever you have, that it doesn't touch the inside of the cup, because that's contamination. So we would hold it over and just pour. You don't have to lip or anything, just it's not sterile. We just pour it straight in there, but you don't want to be all inside the cup is the thing. Okay? And that's probably going to be your favorite check off is that part.
That's why we save it for last.
Save it for last. So that's pretty much it on your check off.
All of that is in your book. Every bit of it.
Insulin and then that.
You're going to do the med part first, and then after you get the meds finished, then we'll go straight to the insulin, and we'll do the insulin, and then you'll go do the reconstitution, and once you've completed that, you'll take what you've drawn up on the reconstitution, and you'll go to show the sites, and then you'll go to the pour. But seriously, on the sites, to me, that's the easiest part. This stuff is the harder part, because you really have to critically think to make sure you don't compromise your patient's safety. Know those landmarks and know how to do it. The injection sites are not difficult. It's just learning your landmarks. And you're going to have to tell me that. You can't say, yeah, that thing that comes off your hip right there. You guys have to start learning the terminology. So you need to tell me superior anterior iliac crest. And, you know, you're going to put your palm on the greater trochanter and place this on the superior anterior iliac crest. And then you're going to move your fingers and you're going to inject right there. And you're going to aspirate. You have to tell us you aspirate, because it's an IM injection.
Between your fingers.
Yeah, and be careful. I put my fingers back some because I don't want to inject myself. I usually kind of pull back a little bit and just go right between there. And ventral gluteal injections are evidence-based, the standard of care. You guys, I'm going to tell you right now, you won't find dorsal gluteal in your book because it's not in there, because they don't recommend it, because they say safety is an issue because your sciatic nerve runs there. So if you're in the wrong spot, you could damage the sciatic nerve. But also effectiveness, they're finding ventral gluteal site is more effective if you look at evidence-based. So on the dorsal gluteal, you look at the butt cheek here, because it's not in your book. So I'll just tell you that. Because they don't want you to learn it. But you're going to need to, because some physicians only want their, you know. So here's the butt cheek. It's kind of round. Kim Kardashian's butt cheek. So we're going to cut it into 4s, and then the injection will be in the upper outer quadrant. That's where we're going to give it. This is the left butt cheek. This is the crack, and then the other butt cheek. So that's the upper. Make better sense there.
So
So it's going to be the upper outer.
show them on the right side where that is.
Oh, the right side would be here, and the upper outer.
And so you do your hand in any certain way?
I know.
I just
Super outer.
clean it.
Stay out of the
and
way.
Then I just, I usually pinch. I like to pinch it up. And a lot of times you'll find if you pinch up that area, and I don't mean like just clamp on them like a lobster, but pinch it up fairly decent and pinch it up, it decreases the blood supply a little bit. And then I vigorously clean it with my alcohol pad like this, just to kind of numb it. And I take one more alcohol pad and I clean right down the middle where I'm going to inject. And then I inject. And the reason I say that, if you want to do it that way, you can. But the thing about it is, when we clean, you clean from the cleanest to the dirtiest, always, just like on wounds. So I would start from where I'm going to inject and clean my way out. Now, if you want to clean it real good and rub it and numb them up a little bit, and then take one more and swipe right where you're cleaning, that's fine. Okay? And then you'll just inject them and aspirate. On the ventral gluteus is going to be the most difficult for you because it tends to be quite jarring, especially for new nurses even for old nurses, and that's why we have a problem incorporating that into practice now. Because if somebody says they're going to inject you right here, do you feel comfortable?
Oh, no.
Knowing that they're going to be going, you know what I mean? And especially when you get those little tiny elderly patients and they have like no adipose tissue, I'm thinking, where is this going to go? Because, you know, even though it's just an inch, it's just kind of jarring. And even for patients, some patients will say, you are not going to give me a shot there. You can put it in my butt and that's it. So, you know, patients have the right to refuse. But just get used to it because they are incorporating it into practice, and that's what they want you to learn, and that is in your book. The dorsogluteal is not, okay? And the deltoid should be not difficult for you. I'm sure all of you have had a shot. And then vastus lateralis we primarily use for what patients? Pediatrics, so be familiar with that. And then your insulin and your reconstitutions. And get familiar with your insulin syringes. Get familiar with your reconstitution. Read the stuff, look at it. Look at your dilutants, what you have. You know, it tells you what you'll have in the end as far as milligrams per milliliter. It tells you how much dilutant to put in depending on which one you pick, the 300, the 400, the 500. It tells you how much you'll have once you've diluted it. And then you just have to look over and say, okay, every mil has 500 or every mil has 400. And you draw. It's pretty simple.
Are we timed on this?
You will be. But we don't push it and ride you, but I can't let you sit there for an hour.
Oh,
I mean, you'll get 20 minutes for the med part, and then we usually give you about 5 minutes for the insulin, because it doesn't take a lot of time for the insulin. And then you usually get 10 minutes for the reconstitution. And then the other two we don't time because those don't take that long. So it'll just basically be those three. But we do have to time it because I've had students before that will sit there all day with their drug books. And I'll say, you've been here for like 3 days now. Are you ready to go ahead because I'm hungry?
We'll never get through it all.
We'd never
if
get
we
through
don't.
it. Yeah. And that's pretty much it in a nutshell, guys.